Good day, everyone attending this webinar today. My name is Geoffrey Bitugume, the team lead for Ultrasound Africa. We are delighted to welcome you all to this webinar. We have attendees from all over Africa and around the globe. We have ultrasound practitioners, sonographers, radiologists, obstetricians, doctors, students, and policymakers attending this webinar today. Our attendees are mainly from Africa, countries including Uganda, Nigeria, Senegal, Ghana, Sierra Leone, Egypt, Ethiopia, Somalia, some from South Africa, Eswatini, Zimbabwe, Tanzania, Malawi, among others. We also have attendees from the UK, also others joining from the EU, Russia, India, United Arab Emirates, as well as Pakistan, among other countries. Our topic today is the intricacies around preeclampsia. Now, the Fetal Medicine Foundation in UK reports a global burden at about 500,000 fetal or newborn deaths and around 46,000 maternal deaths per year. All these attributed to preeclampsia. This qualifies the need for us to have such a webinar so as to help down these statistics. The main agenda for today will include presentations from our distinguished speakers, and the last segment of this webinar will include a question and answer session. Also, there will be quizzes. Please watch out for them. Also, look out for information in the chat box. You can also send through your questions and opinions through the chat box. I now take the honor and delight to introduce our very first speaker, the very well-known scholar and researcher. He is a professor of obstetrics and gynecology, Professor Joseph Ngonzi. He's also the Dean of Medicine at MUST. Uganda is fortunate to have a top researcher in the field of obstetrics. Professor is extremely busy. We are extremely delighted that he has created time to teach on this platform on a very important topic aimed at saving both babies and mothers. Thank you, Professor Joseph Ngonzi, for accepting our kind invitation to this webinar to speak about preeclampsia, its burden and clinical presentation, as well as diagnosis and management. I will now give you the stage to speak, Prof.
It's a great delight to be part of this meeting. I don't take it for granted. My name is Joseph. I work in Uganda. I live and work in Uganda. I've studied largely in Uganda, and I've interfaced in a few other places. I've done part of my fellowship in Canada and my PhD in Belgium, but I'm now permanently based in Uganda. I work at Mbara University of Science and Technology. I was given a topic, a few parts of a wide topic on preeclampsia or hypertensive disorders to discuss, and I'll get into that. Should be done in the next 15-20 minutes. Okay. So I'd given a little bit, well, those are pictorials of the world I'm involved in academia here, and also part of the clinical world. I was asked to get into a little bit of introduction on preeclampsia, sorry, on hypertensive disorders in pregnancy, and then we get down to preeclampsia. Hypertensive disorders, and in particular preeclampsia, eclampsia, are a leading cause of mortality in many settings globally. Currently, in my country, it's the second leading cause of maternal mortality, and the region where I work, it's the leading cause. It's overtaken postpartum hemorrhage for the last 3 years, and so it's becoming increasingly a great burden, and our skills have to be improved to be able to curtail the deaths and morbidity arising from these otherwise preventable diagnoses. Hypertensive disorders can be classified largely or traditionally into 4 categories. There's what we call gestational hypertension, and then preeclampsia, chronic hypertension, and then preeclampsia superimposed on chronic hypertension. Those are the 4 major categories of hypertensive disorders in pregnancy.
So, Joseph.
Slide number 4, I was just giving the 4 major categories of hypertensive disorders in pregnancy. And then just a brief summary of each of those. One, when we talk of gestational hypertension, this is where we have high blood pressure with no proteinuria, no protein in urine, and usually this blood pressure returns to normal within 12 weeks, by 12 weeks postpartum or post-delivery. And this diagnosis is made postpartum. And when and gestational hypertension is where we have high blood pressure developing for the first time during pregnancy, and we describe it as hypertension after 20 weeks of gestation in women known to be otherwise having normal blood pressure before pregnancy. And when it comes to preeclampsia, which is a major killer of our mothers and also a major cause of morbidity in our mothers and babies, preeclampsia is a multi-system disorder which is characterized by raised blood pressure and also protein in urine. And when we talk of protein in urine, we are talking of 300 milligrams in 24 hours, or when you have a random measurement of 30 milligrams per deciliter or 1+ dipstick, that makes it quite suggestive and can be classified as mild and severe preeclampsia. Historically, we used to have mild, moderate, severe, but now we're talking of mild and severe. And when it is severe, that's when we have raised blood pressure, we have significant protein in urine, and also signs and symptoms of end organ injury. And mild preeclampsia is, when that happens, there's absence of any of these findings here. And the third category is the preeclampsia superimposed upon chronic hypertension. And this is when we talk of raised blood pressure antecedent to pregnancy, and it's usually detected before 20 weeks of gestation, unless in rare cases of gestational trophoblastic disease. And this, there's persistent hypertension even long after delivery, long after the 12 weeks postpartum. So these are some of the, the symptoms and the findings that may tell you that there is severe preeclampsia, and these emanate from the impact that this disease may have on some of the organs. Symptoms of liver capsule distension, CNS dysfunction symptoms, hepatocellular injury, the blood pressure raising way above 160 in terms of systolic and 110 millimeters of mercury in terms of diastolic on 2 occasions, at least 6 hours apart. We have thrombocytopenia, reduced platelets, protein in urine of that level. We have fetal growth restriction, pulmonary edema. So any one of those, one or more of those, would be, would indicate, would be a great criteria for severe preeclampsia. And in there we have what we call eclampsia, which is development of grand mal seizures in a woman with preeclampsia in the absence of other neurologic conditions that could account for seizures. You also have what we call HELP syndrome. Now, each of these is a whole topic of itself, but when you find, in a woman, having some of these findings, then you know that this is really gross. HELP syndrome is what we call hemolysis, elevated liver enzymes, and low platelets. And this is also a severe form of preeclampsia. And chronic hypertension, which is the fourth category. This is where we have systolic blood pressure equal or more than 140 millimeters of mercury, or diastolic blood pressure equal more than 90 millimeters of mercury, that antedates pregnancy or is present before 20 weeks of pregnancy, but also persists longer than 12 weeks post-delivery. It can be essential, meaning it can be primary or secondary to a variety of other medical disorders. In terms of clinical presentation, I just want to make this, these statements. One, that many of the clinical features of preeclampsia can be explained as responses clinically to a general dysfunction of the endothelium. And these features may result from mild to severe microangiopathy of the target organs, including the brain, the liver, the kidneys, the placenta, and many others. And potential maternal sequelae can also develop, including pulmonary edema, hemorrhage within the brain, hepatic failure, renal failure, and of course, if uncontrolled, may end up into a mortality. You can also have visual disturbances, headache, especially when you have CNS involvement, epigastric pain, thrombocytopenia when you have liver involvement, and also cardiovascular. You can have symptoms and signs of abnormal renal function, symptoms and signs of abnormal liver function, in summary. And under each of these organs, of course, there are detailed symptoms and signs, but because of the time available, I thought I could just give us a hint on what is possible. When it comes to management, of course, traditionally, when we talk of management, you're talking of examination, investigations, you're making diagnosis, and then the treatment. So some of the common lab investigations that you want to do, one is urinalysis. You can do a dipstick, but also you can do some blood tests, including a complete blood count, where you look at the hemoglobin levels, look at the platelet levels to see whether they are, less than the lowest limit expected of 150,000. Look at the reticulocyte cell count. It's possible to have a spherocytosis or reticulocytosis, and look at the blood gases, pH, bicarbonate levels, and the serum electrolytes, especially sodium, potassium, and chloride. And you can also do liver enzymes, especially ALT and AST, serum lactate dehydrogenase, renal function tests, including serum creatinine, most importantly, and urea and uric acid. Magnesium levels in centers where it's possible to measure this is very important, especially when a mother is on treatment and they are getting magnesium sulfate. You want to monitor to see whether you're getting into the toxic levels or not. When it comes to imaging, of course, there are experts on this call who can give us details about imaging, but most importantly, ultrasound scan to look at the fetal biophysical profile, the fetal biometrics for intrauterine growth restriction, umbilical artery Doppler, hepatic scans, uterine artery Doppler velocimetry, and of course others as may be indicated. When we talk of prevention of preeclampsia, the World Health Organization recommends certain measures, to prevent preeclampsia, but also a number of Cochrane systematic reviews arising out of a number of randomized controlled trials have recommended the following. 1, daily calcium supplementation, low dose aspirin, usually or preferably initiated before 20 weeks of gestation for women at high risk, and antihypertensive therapy for women who may have an indication for that treatment, maybe chronic hypertension, and so there's need for them to be optimized in terms of their high blood pressure treatment. Management of preeclampsia or eclampsia, definitively the liver of the fetus and the placenta usually causes or brings some bit of relief to the damaging effects of preeclampsia, eclampsia on the cardiovascular system and the other organs within the woman's body. And this management aims at minimizing further pregnancy-related complications, avoiding unnecessary prematurity, and maximizing maternal and infant survival. The goals of management are basically 3. For preeclampsia, meaning we have got no fits, it's important to prevent convulsions. And if it is eclampsia, it's important to treat the convulsions. Eclampsia means that the convulsions or the seizures are there. Number 2, it's also vital to control or treat the high blood pressure. And of course, definitively deliver the placenta in the fetus in the safest and quickest means possible. In terms of controlling hypertension, it must be noted that lowering blood pressure does not affect the cause of preeclampsia, very importantly. Untreated severe hypertension increases the risk for the complications in the organs that we had already highlighted, in the CNS, in the kidneys, in the liver, in the lungs, in the placenta, and that may cause additional complications. Severe hypertension of that level, as showed, usually the first line of treatment is intravenous labetalol, and alternatively, in settings where that is not easily available, hydralazine has played a big role. And when it comes to oral hypertensives, methyl dopa or nifedipine have also been found to be of help. Controlling acute hypertension using acute therapy, labetalol, hydralazine, those are the details of the dosages. And clinicians, when they do not remember these dosages, usually BNF is close by. In terms of maintenance at hypertensives, especially on mothers or patients who are on oral therapy until delivery, the drugs we've spoken about them and the target blood pressures are as showed. When it comes to preventing fits, remember this was one of the goals of management. Commonly, we use magnesium sulfate, and there are details on the dosage of magnesium sulfate and their protocols of administration. In our setting and much of the sub-Saharan Africa, the Pritchard protocol is used. And there are doses that are given for 20% magnesium sulfate, how it is constituted from the 50% magnesium sulfate and how it is given. So magnesium sulfate is largely used for preventing the fits, and it's important to have the serum levels monitored. And if there's toxicity of magnesium sulfate, the effective antidote is what we call calcium gluconate. When it comes to delivery, of course, there are certain indicators that may determine your mode of delivery, whether operative or vaginal delivery. And when it comes to operative, of course, we reserve a cesarean section for the traditional indications of cesarean sections. But these other features that are indicated here may cause you to want to deliver this mother, using this quickest and safest modality. And if it comes to a vaginal birth, of course, it's important for the attending clinician to do a Bishop score and look at how faster a vaginal birth can happen in case there's no contraindication to a vaginal birth. After delivery, very important, this is my last slide, it's very advisable to monitor the blood pressure every 15 minutes for 2 hours. Now, this is immediately after delivery, and monitor the vital signs, urine output, and look at the urine protein for at least 48 hours. Continue the antihypertensive to maintain the diastolic blood pressure around 90, and these mothers can be discharged when the blood pressure is stable and there is no urine protein detected. Hypertension usually resolves with the birth of the baby, but may persist in case of undiagnosed pre-existent hypertension. This brings me to the end of my brief basic presentation around the topic of interest. Thank you once again for listening, and thank you, Geoffrey and team, for inviting me to this very important webinar. Thank you very much.
Thank you, Professor Ngonzi. We thank you very much. We are so grateful for this insightful talk. Professor Ngonzi, as a teacher and an expert on this topic, he brings out the intricacy of preeclampsia in a simpler way for everyone to understand and learn. I'll just let this across for questions to Professor Ngonzi. Please send them through the chat, and these will be answered during the last segment of this webinar. As well as at the end, we'll ask those with questions to raise their digital hand on your gadget so that the good professor will be able to answer your questions at the end. All right. Again, I'm delighted to introduce another top researcher in the field of obstetrics. This is none other than Dr. Sam Ali. Dr. Sam Ali is a research fellow, Makerere University Hospital, Kampala, Uganda, and he's a winner of several grants, research grants. He's a research lead for a number of researches and grants, and his field of expertise is clinical epidemiology, medical imaging, and diagnostic radiology. He has a bias in obstetric and gynecological ultrasound. Dr. Sam Ali is a principal investigator on the in utero project. That's the stillbirth in high burden settings, and for room for improvement using the biomarkers and ultrasound technologies. This is termed as the iTech research project. I know many of you have heard of this. This is a global research project taking place right now, and he's a principal investigator for this. He is part of the 5 key investigators who have recently led the Delphi process to develop a definition for stillbirth near miss that will be used within the in utero program as an outcome definition for predictive models. Sam has over 10 years of experience working in both rural and urban hospitals. These are clinical settings in Uganda, with extensive experience and expertise in Doppler ultrasound assessment of risk in resource-constrained settings. And his PhD is actually around these areas, and so he's very resourceful. He has demonstrated the feasibility of embedding advanced ultrasound technologies into sub-Saharan Africa clinical settings. Further, he contributed to the World Health Organization Commission manuscript providing global guidance on the use of lung ultrasound in COVID-19, which is extremely vital for pregnant women. He has held teaching roles at Ernest Cook Ultrasound Research and Education Institute, Kampala, Uganda, since 2018, where he supervises postgraduate students. He is enthusiastic about maternal-fetal global health, prediction modeling research, and clinical application of artificial intelligence in pregnancy imaging. He is keen to apply his skills to contribute solutions to maternal, fetal, and perinatal health problems. And now I set the stage for Dr. Sam Ali.
Thank you so much, Jeff, for the kind introduction. Can you confirm for the kind introduction and of course for the invitation to come and give like a brief update, mostly from the research perspective. So my colleagues, Vitus, who I work with, will also cover some other aspects of the technique, and Edwin will also cover some aspects. So I'll give most of the research perspective. And I would, of course, very much want to thank Professor Joseph for giving that very broad introduction, very enlightening. And of course, it has made it easy for me. I think in the subsequent slide, I think slide 2, could you, so he has already emphasized most of, yes, Jeff, yes. He has already defined preeclampsia, and of course, it came from a broader perspective of hypertensive disorders in pregnancy. And he has highlighted on most of these issues. Most importantly, that this can resolve around by 12 weeks of pregnancy. And ideal, of course, if it doesn't resolve, then probably this that could be considered as chronic hypertension. Another thing that is important to highlight, of course, which he has already said, is most of the mothers who have preeclampsia have the highest risk of both having of maternal and perinatal adverse outcomes. And it contributes over 13% of maternal severe obstetric complications. I will not go into the details of the severe and mild forms because this has been ably covered by professors. Maybe it'd be very nice if you could move to the next slide. Yes, so I'll just hint a bit on this because this is quite important, because he also mentioned quite some of these risk factors. So there are two categories of risk factors here. You can see the high risk category and the moderate risk category. From the high risk category, if a woman has any of these risk factors, then the risk increases by about 8% of developing preeclampsia. So like he said, the most important goal of preeclampsia screening should be to prevent it from happening. And I think if you begin therapy as early as 16 to 20 weeks, at least it's possible it's been shown actually, that trial that has been published in the New England Journal of Medicine has shown that actually you can reduce the risk by about 60%, which is quite very important. Of course, this presents a daunting challenge in our setting because the majority of the women present quite late for their NC. So we have a huge task to do, not just to do research to inform evidence, but also to try to see if we can encourage women to come as early as 20 weeks, at least if it's possible. And this is one of the things we're doing in most of our research. So I also wanted to just highlight these factors because nearly all these factors, maternal factors, feed into the current model that is used for prediction of preeclampsia. Of course, with ongoing research, of course, maybe we could make some revisions if we find better markers, but nearly all these markers that you see here fit into the prediction model for stillbirth. Sorry, sorry, for preeclampsia. And of course, the focus of my talk will be mostly on prediction, like I said, but the role of ultrasound in preeclampsia is quite broad. Like he did mention, that could be very important as well for monitoring fetal growth. And because you do know very well that preeclampsia is, mostly preterm preeclampsia is strongly associated with fetal growth restriction and stillbirth. So it is important that if there is a high risk case or a suspected woman, at least you can do very good growth assessments, and also nice to perform at least the umbilical tree Doppler, because for sure for now we know at least it's one of the recommended Doppler assessments in pregnancy. Of course, there is also emerging evidence showing that you could also in the late trimester, you could try to use cerebral-placental ratio because it's a very good indicator for intrauterine compromise. Actually, there's a very good publication that we put in that we published in BJOG, highlighting how this is a very essential marker. Of course, we need more evidence to support it. Maybe Jeff, moving to the next slide. I don't see the next slide. Yes, thank you. So, like I did say, okay, next slide. Yes, this one. Yes, I will just be talking about the added value of ultrasound, and most importantly in the screening perspective. But like I already said, also it's important for to inform management. There are different scans that could be helpful, and of course gross monitoring scans, and of course if the baby also has abnormal findings like maybe absent flow in the endosteric flow, maybe it's nice to closely monitor that baby with subsequent scans. And also of course in multiple pregnancies, the assessment or the subsequent assessments are almost every 2 weeks, so it's important that that ultrasound is utilized in the management. But the talk here is just focused on the prediction aspect. So currently, I think this is the best model we can say that we have for prediction of preeclampsia. Jeff, I think the previous slide. The best model we have for prediction of preeclampsia. And this model has various parameters, including maternal factors, the factors that I talked about in the previous slide. So all those factors feed into this model. And you see with those factors alone, we have an AUC of about or discriminative ability, like the ability of a clinical prediction model to differentiate or so this is more prognostic, to predict whether a woman is likely to develop preeclampsia. And you see the ability, it has an AUC of about 80%. And of course, this may not be very clinically like very significant or very highly discriminative, because of course for a very good model or clinical tool, we at least expect a model with a discriminative ability of about around 90% or 95%. So that's why these researchers went ahead to look at other parameters, and you can see mean arterial pressure. And I'll focus more on the added value of ultrasound. You do see with adding only uterine artery Doppler, you can increase that discriminative ability from 81% to about 90%. Of course, clinically relevant, but of course, the less false positive you have, the better. So usually you want to aim for a model which has a very high discriminative ability if you can be able to achieve it. So, but you can see from the look of things, adding uterine artery Doppler just to maternal factors, you achieve very good discriminative ability. Mostly for very preterm or early onset of preeclampsia below 32 weeks. And of course, for preterm preeclampsia at around 37 weeks, you see that the discriminative ability is also a bit low. So it means if you use only this, it may not work. But surprisingly, of course, this doesn't perform well in term preeclampsia. And I think it's for the entire, even if you add other parameters, you can see that for term preeclampsia, prediction of term preeclampsia is a bit problematic or challenging. So if you go ahead to add other parameters, of course, which is not the main topic of the day, other biochemical markers, mostly PLGF, you see that the predictive ability tremendously increases to about 95 points, about 96% in very preterm preeclampsia. And for you can see as well for term preeclampsia, that's preeclampsia happening after 37 weeks of gestation, it is still a bit low. So adding other biochemical markers, for instance, like PAPE, you see that the predictive ability doesn't change much. And I think the model that has maternal factor, mean arterial pressure, uterine artery, Doppler, and PLGF or placental growth factor actually performs well, very well. Of course, one of the major challenges that will be highlighted here is that these biochemical tests are not very available in our setting. And at least if we don't have this, could we maybe, of course, use the other parameters which we can easily get, and then still with uterine artery PI, you can still achieve very good predictive accuracy. Yes, maybe next slide. Yes, so I would also want to highlight that there's been also ongoing research to identify other beta markers that could be used. And ophthalmic artery is one of those promising new ultrasound markers that could be helpful. And maybe I will also focus a bit on this, given that it's easier to access. It's a quick procedure. And at times, uterine artery is a bit complicated to do, more so very late in pregnancy, and also the reproducibility is not at times very good. But it's the best choice we have right now. But ophthalmic artery seems a very promising one. Placental volumes have also been investigated, but very limited evidence on this, I must say. And placental perfusion indices are also some of the novel areas that some researchers are focusing on. And of course, most of the Doppler indices we've been getting have been providing multi indices. But if we go, we try to explore techniques that allow us to estimate the actual volume of blood perfusing the placenta. I think this is one of some of the novel areas that are being researched on right now. For the biomarkers, which I'm not going to spend a lot of time on, there are, of course, other many new markers that are being explored, and including cardiovascular markers. I will not focus so much on that. Next slide. Yes. So, like I did say right now, the best shot that we have for prediction is uterine artery Doppler, but can we also think about maybe a test which is easier to perform and easily accessible? And I think ophthalmic artery has gained most recently. There's been a lot of ongoing research around this. And why? Because I think it's one of the most promising markers, like I did say, and it will be easier to implement this in settings like LMICs, where you can easily perform this measurement. Because I think also performing uterine artery Doppler to the quality that is desired, I think it's one of the most, it's a very technical examination. Yeah. So ophthalmic, very parameters have been explored, but you notice that the percentility index doesn't seem to have a very good predictive performance. And a PSV of about over 23 centimeters per second seems to be PSV seems to be most promising velocimetry index for use in this prediction. And most importantly, the ratio seems to be the ratio of the second divided by the first PSV seems to be the most promising marker. But you can see, like the uterine artery, whose predictive ability is about 58–60%. The same applies for uterine artery, for this ophthalmic artery Doppler. Its predictive ability is also quite low when used individually. But of course, there's been some research around it to show that if used with other parameters, for instance, the maternal factors that I've talked about, it could be a very promising marker. And like I did say, the ratio seems to be performing better than either the first or second peak systolic velocity. And I think that's what we can see from most of the new publications coming out. Jeff, the next slide. Yes, so this is also to me a very important slide because like I did say from the beginning, that most of these biochemical markers currently access is quite a challenge and a bit expensive. And this research is quite exciting because if you look at the ratio, its performance, in addition to the maternal factors, is extremely good. And I think this can be a potential replacement in settings where we are not able to access biochemical markers, then this is going to be a game changer for the prediction of preeclampsia. And of course, we're also trying to explore if this can also be used to predict stillbirth as well. But this is the main message in this slide, that this could be a potential replacement for PLGF, or placental growth factor, or PLGF. The ratio, of course, the ratio of PLGF and S3 PLGF seems to be better than using individual markers. Yeah. So that's the main message in this slide. You can see that the performance is nearly the same. A model having those similar factors, and then including ophthalmic artery Doppler, and then a model only having the biochemical markers. All right, Jeff, next slide. Yes, so we've been trying to expand on our understanding on the evidence regarding ophthalmic artery Doppler, most in LMIC. I think there's one review by, I think, Calafat. I think I don't remember the author by name properly, but I think it's one of the publications I've referenced here. There was one publication on this, but that was at the time published around 2018. And of course, meaning the research was done sometime earlier, and there's been a lot of emerging evidence on ophthalmic artery Doppler, and we gained interest in this. And there's a group I'm working with, and Joseph is from Ghana and is leading this systematic review. And we are hoping that we could actually get up-to-date evidence on the potential role of ophthalmic artery Doppler. We have also received funding from Bill and Melinda Gates Foundation, where we are going to try to understand the uterine artery Doppler waveform and its relationship with the cardiovascular system and the ophthalmic artery itself. So in this, we are measuring all those maternal factors. We are taking placental volumes, and we'll also be taking the uterine and ophthalmic artery Doppler measurements, and maternal hemodynamics, like I told you, because I think it looks like maternal cardiovascular maladaptation plays a very essential role in pregnancy growth, and it's one of the markers that we have not been adequately explored, and right now seems to be some of the most promising markers that can help actually explain the pathophysiological mechanisms behind preeclampsia and stillbirth. Could you go to the next slide? Yes. So we also have this ongoing study, another study called the ITEC study, where we are collecting quite a lot of data to help us actually predict stillbirth. That's the primary goal of that study. And of course, like you do understand, I did say preeclampsia is a major risk factor for stillbirth. And of course, we are collecting measurements in that regard. And we're also working on coming up with potential models for preeclampsia, of course. But though the primary interest in the study is to establish prediction models for stillbirth, with the overall goal of reducing the burden of stillbirth globally in the next 5 to 10 years by about 50%. So this is a program-wide approach, and we are lucky to be part of this program. And we're also collecting ophthalmic artery Doppler measurements. And you can see from this publication by those of Kypros, this is just very recent. And you can notice that actually there are very limited studies, large-scale studies on this, and most importantly from an LMIC context. And we are very proud to really try to look into this. And we are collecting all these other parameters, the ultrasound, hemodynamics measurements, and using ultrasound cardiac output monitors. Also, like looking at arterial stiffness, using the arteriography, and we are also looking at quite a number of biomarkers and collecting some lots of samples that will be used for current analysis and future analysis. Of course, we have a goal or a vision to develop a point of care kit. Of course, this will be dependent on the markers that we identify, and we hope we are able to do this within the scope of this project. If we are not able to do this within the scope of this project, given the huge amount of work we have to do, we are looking to this because, like I did say, most of these markers are really hard they are very costly, and also the tests may be hard to access even if we have them in prediction models. That's why we're thinking about alternatives for these biochemical markers as well. Yes, next slide. Yes. So this is just my conclusion. Of course, it's a very short talk. There's some work that we just concluded in one of the regional referral hospitals in eastern Uganda, and unfortunately, the data collection spread until the last week of August, so the team was unable to quickly enter this data. But hopefully, I have another platform I could share this very promising, very good evidence where we are looking at actually trying to look at in preeclamptics and then different classifications of hypertensive disorders of pregnancies, and also in normotensive, and you're trying to look at some of these markers I've been talking about. And this was mostly also like more of a small scale to inform a large scale study. I hope I can have a chance to share this with you. But what I can say is the best marker we can now, ultrasound marker that can contribute to the prediction is a uterine artery Doppler. And this is of course more valuable when used in combination with other tests and not used in isolation. When used in isolation, it has a very poor predictive value. Then there are lots of emerging markers. I would also encourage the rest of the colleagues who are researchers to try to explore these markers. Of course, I know placental volumes has been one of the challenging one, very poor predictive value, and because also poor reproducibility. And of course, it's time consuming, but there are now new technologies that are coming up that you are able to get these volumes very quickly. There is artificial intelligence that can support with segmentation. And so there's a lot we can now explore with these novel tools. Yeah, like I did say as well that we are trying to think about exploration of predictive markers, biochemical markers, and then put them on a lab on a chip device. And I'm hopeful that this will be helpful to make these tests accessible. Yeah. Thank you so much, Jeff, and thank you all for listening. Yeah.
All right, thanks, Dr. Ali Sam, for this very wonderful talk. Wow, this is something really that is sinking in, and I'm very excited about the the point of care kit, the biomarkers. I hope this comes really to fruition, that we can apply in the resource constrained areas in Africa. Thanks very much, and coordinator and trainer of trainees for the iTech project that Dr. Ali Sam is actually talking about. So it's all about stillbirth in the high burden settings, and he's stationed at Makerere University Hospital since 2022. Vitus is an ultrasound educator here at Ultrasound Africa, as well as he also oversees the development of ultrasound protocols, guidelines, and the accreditation process here at Ultrasound Africa. He holds a master's degree in diagnostic ultrasound. Vitus has worked with Dr. Ali Sam, as you just heard Dr. Ali Sam speaking, and they have been working on studies related to preeclampsia, intrauterine growth restriction, and the wider obstetric ultrasound, especially in the resource-constrained areas. And he will be sharing some of the findings and also a little bit of data from some of their research projects that Dr. Ali Sam is spearheading. I now hand you to Vitus. Vitus, I give you the floor to discuss the role of ultrasound in preventing fetal and maternal death.
Thank you, Tugume. Hopefully you can hear from me, and hopefully my screen is visible.
Yes, it's very visible, and you're very clear.
Thank you very much, Professor Joseph Ngonzi. Thank you very much, Dr. Sam Ali, and thank you all for attending. My role is just brief. I also have a brief presentation, not more than 15 minutes, just to understand what is the role of ultrasound or imaging in the perspective of these pregnancy hypertensive diseases, and majorly preeclampsia. Now, like Professor has demonstrated, and like Dr. Sam has ably demonstrated too, there is a lot of organs, maternal organs that are affected. Like you can see in this picture, cardiovascular, cerebral, pulmonary, hepatic, then of course, hematological, renal, and all this at the end of the day has an effect on the fetus. So we are looking at the perspective of using ultrasound in reducing maternal and fetal morbidity and motility. Indeed, this being a low income or low resource or constricted area, how can we use the limited resources that we have? Like Dr. Sam has just demonstrated who is at risk and what are the parameters or prediction models that we use. Now, in the perspective of ultrasound, like he has demonstrated, we majorly use the uterine artery, like you have seen among all, above all the, so many parameters used in prediction. The uterine artery majorly is used in screening and prediction, and its effective is majorly achieved at the level.
Vitus, your screen is not, your slides are not moving. If you're able to move the slides, and also we're having a challenge with your internet, the internet on your side.
To detect disease before it actually happens. And most of the Preclampsia takes. You can see the Doppler images.
We don't see the images yet. The slides aren't moving at the moment. We're still on the first slide. If you could move, yeah. Now that's great. Thank you.
Okay, this is slide 2. I think let me leave it in this mode. So I was saying the uterine artery has 2 techniques. In the first trimester, we sample the uterine artery at the level of the internal os. And basically this will demonstrate, and this will be the wave which is characterized by. But of interest in the uterine artery, we are interested in the pulsatility index. And if it is greater or equal or greater than 90, then most likely it is showing us we are having high chances of this woman developing complications or pregnancy-related hypertensive diseases. Now, some arterial pulsatility index. And of course, in the first trimester, we have 2 ways of doing this scan. It could be transabdominal or transvaginal. These methods affect our PI, like you can see. We presume that the difference here could be because of the different attenuation properties when you use transabdominal and transvaginal. Transvaginal is more close to the area of interest compared to the method you have used. And remember, pulsatility index, like it is stated here, you have to put it in context of the gestation age. We understand as gestation progresses, the pulsatility index is supposed to reduce. So do not take it in solitary. But also there are other factors that govern using the PI. For example, other maternal factors or pre-existing other conditions or sensitivity might be low. He talked of the emerging screening markers, the ophthalmic artery. Now, the ophthalmic artery, we all know, you just isonate the eye and you look posteriorly for the optic nerve, which is this hypoechoic structure we are looking at. And then when you pull or Doppler medial and superior to it, you'll be able to pick up.
We can't see your slides.
No, it is still the same image.
Okay, you're still on the.
It is still the same slide.
Okay,
the image on the right. This image here. So this is the hypoechoic nerve or the optic nerve sheath, and then what is carrying up there is our ophthalmic artery. Like Dr. Sam said, we use a ratio. So you see it has systolic 1 and systolic 2. This is PSV1 and PSV2. Now we don't use the pulsatility index like you mentioned because its sensitivity and specificity is so low. But when you use the ratio of PSV2, this one, to PSV1 has demonstrated or is showing much better sensitivity and discriminating abilities compared to the pulsatility index. And this is very easy. Each one of us can try it out on their own, on your own eye. It is very easy. It is much, much, much easier and much more easier to tolerate than doing the uterine artery in the first trimester. Now, the other good thing with the ophthalmic artery is you can use it all throughout the gestation. It is not discriminatory to first trimester. Then as pregnancy progresses, now past the first trimester, I hope you can see slide number 3.
Yes.
So after the first trimester, of course, now we are towards more chances of this woman either developing. Of course, sometimes not all cases that you will see a high risk of developing those hypertensive diseases. Some may actually go up to term pregnancy with no any of that showing symptoms. But still, again, when you do this in the first trimester and you follow up in the second trimester, the uterine artery is showing good evidence that it can actually predict early onset of PE up to about 8 compared to much later in pregnancy. Again, the approach here is slightly different from the first trimester. Whereas in the first trimester, we prefer to look for the uterine arteries at the level of the internal os on either side, the left and the right, because we said we do the mean. Now, in the second trimester, what we do, we now sample the uterine artery at the level where it is crossing the iliac vessels. And you sample about 1.5 to 2 centimeters just above it. Now, we have quite a number of variations, like you may have done in any other vascular ultrasound. You are going to have variations of having so many bifurcations, or you have this uterine artery actually giving out more bifurcations than its destination. Now, if you find it having bifurcations maybe above the level where the iliacs, where it is crossing the iliacs, we prefer you sample before it reaches that bifurcation. We understand from hemodynamics, when a vessel branches, you're going to have changes in these velocities. So in the second trimester, sample at just 1.5 or 2 centimeters above the iliacs. And again, like we said, whether you did transabdominal or transvaginally, take into account that you will have a difference in the mean pulsatility indices that you will register. And of course, like we said, as pregnancy progresses, you're supposed to have an evidence of gradual reduction in the mean pulsatility index, about 15%, especially for pregnancies between 20 to 24, where most of these PEs develop at. So renal ultrasound, especially Doppler, has also demonstrated some abilities, but the limitation with renal Doppler is usually it will not predict ahead of time. Usually already these hypertensive disorders will have set in. And like Dr. Ngonzi demonstrated, this hypertensive disease, especially preeclampsia, affects cardiovascular, renal, hepatic, and of course the hematology. But if you look at the renal resistive index, of course, someone may already have early onset, but they have not exhibited severe symptoms. So if you do renal and your your RI is much greater than 0.59, now this is highly discriminative, then the chances are you are having nephropathy or renal diseases. But it is also prognostic for chances that this mother is going to suffer cardiovascular comorbidities. And the sensitivity is so high, but the specificity is so low. There are other conditions that could cause renal diseases. Now, if you don't have Doppler, then something that is a little bit close, though sensitivity and specificity are a bit low, you can use renal volume. If you don't have Doppler, you can use renal volume. And this is how, of course, you take the longest length of the kidney and its width. Then, of course, you also do the thickness. The higher the volume, of course, the higher the chances that we are having chances of developing preeclampsia or hypertensive diseases. Now, why does this increase? It is suggested with these hypertensive diseases, edema most likely, and of course, that renal failure in early phases is the one that causes some bit of renal volume increase. That is, if you are unable to use Doppler, I think, which is the most of what many of us are doing. We have very few Doppler machines, or in most cases in our low resource setting, in our villages, we don't have renal Doppler. Now, besides that, we look at the factors, so after looking at some of those other screening markers, and like Dr. Sam has ably demonstrated, also Dr. Ngonzi said, if one of the management ways is to deliver the fetus or the placenta. Of course, some of the causes of these hypertensive diseases are to do with trophoblastic invasion or placental perfusion. Dr. Sam already said we do perfusion of the placenta. Those are sensitivity and specificity things we are trying to do. In ITEC, we are trying to do some of the placental power Doppler volumes. Now, what we are looking at is also something that is developing. We are looking at what we call fractional moving blood volume. How much blood is flowing through this placenta. That is in addition to the Dopplers of the placenta. For example, you look at the spiral arteries and fetal placental arterioles. How is the perfusion? What is the pulsatility indices? And then we also do biometry of the placenta, the thickness and the length. And we usually do this. Now, as we measure the length, we don't just put a straight line. We do a trace of the length, because the placenta suddenly is not a linear organ. So we do a trace of the placental length, and then we also take its thickness, much better or perpendicular to it at the level of the cord insertion. Of course, you have to use color Doppler to determine where that cord insertion is. Besides the placental perfusion and the biometry, we have placental lesions. They can be hematomas, benign or malignant lesions. They are quite different. Going into the details is much more beyond the scope of this presentation. But the placenta is something we also need to focus on, in addition to the others that we have talked about. This is just a few examples of the placental lesions or hematomas that we majorly most commonly meet. These we can look at our own time. So, like Dr. Ngonzi and Dr. Sam have said, one of the challenges or in management of some of these hypertensive disorders or preeclampsia, when it comes to the maternal side, most of what happens is remodeling of the maternal cardiovascular system. Now, The old traditional method is doing maternal echo. And usually what happens, you'll find reduced cardiac output or cardiac function. And more especially, you'll have remodeling of the left ventricular walls, either the septal or the lateral walls. So if you are able or you are nearby, you can also do an echo, a maternal echo, and it can easily tell you how much the maternal cardiovascular system is being affected. Dr. Sam has ably told us there's new inventions and there's new methods. We know an echo needs skill and expertise and high skill, and it's time consuming, but there are newer methods that are coming up. Maybe perhaps we can wait on ITEC to give us the results much sooner than this. Of course, Dr. Ngonzi ably demonstrated some of the other consequences of these hypertensive disorders. You have maternal pulmonary edema. Now, we understand we rarely have to do X-rays, chest beat, a chest X-ray, or high resolution CT scan. Ultrasound has equally good sensitivity and accuracy in detecting pulmonary edema. Like you see in this image, we have more than 3 vertical lines, what we call the B lines. Maybe lung ultrasound will be a topic that we'll also look at, but ultrasound can easily detect any anomalies as far as the pulmonary is concerned. And it gives us much better opportunity because we have avoided ionizing radiation, especially in the perspective of this pregnant woman. Lastly, but not least, and to the mother, sometimes Professor Ngonzi has talked of cerebral hemorrhage or cerebral edema. Sometimes the causes of these seizures is because we have cerebral edema or cerebral hemorrhage. Again, ultrasound is good and sensitive. We use, again, the optic nerve sheath. You measure the diameter, just 3 millimeters from the optic disc, which is point A here, 3 millimeters posterior to it. Then you just measure the diameter of the optic nerve sheath, and it will ably give you a good parameter. Anything less, more than suggesting to you a high risk of cerebral edema, cerebral hemorrhage. Going down to the fetus, now we have looked at the effects on maternal, especially placental and cardiovascular systems. Of course, it has a trickle-down effect to the fetus, like Dr. Ngonzi and Dr. Sam have demonstrated. And what we look out for here is usually fetal weight or fetal abdominal circumference less than the 3rd centile. There is growth customized charts, so many reference ranges. You can look out for them and have an option of what you're looking for. But besides this, we also look for abnormal Dopplers, and among them is the umbilical artery, where we look at either absent or reversed end-diastolic velocity, which are good markers of fetal growth restriction. Or if you have a middle cerebral artery or the cardiopulmonary, the cerebroplacental ratio less than the 5th centile. Of course, like Dr. Sam ably demonstrated, we are trying to look for as many predictors as possible. Of course, besides these other ones, FGR causes a lot more of fetal cardiovascular compromise. And among the other parameters that we look at is absent or reversed A wave in the ductus venosus. Now, the ductus venosus, we know it's one of the first shunts in fetal vascular supply. So once you have an absent or reversed A wave, in addition to what we have already said, the fetal weight and our abdominal circumference, then absent or reversed umbilical abdominal circumference or fetal weight less than 3rd centile, in addition maybe to absent or reversed umbilical Doppler or CPR less than the 5th centile. And then if you have absent or reversed A wave in the ductus venosus, then you are going into much or severe forms of fetal growth restriction. And this is common. Many of us miss this because we will see some of the challenges why we miss this. Now, as I try to wind up, we are trying to prevent and reduce maternal and fetal morbidity and mortality. Now, the biggest challenge with these pregnancy-related hypertensive diseases or preeclampsia, if we have lots of preterm births and a lot of stillbirths, then of course we have a lot of those maternal complications. Now, as regards to preterm births, Dr. Sam and the experts have given us some of these definitions. You'll check out for them. In our context, preterm birth is birth less than 37 weeks. Definitely, if you have growth restrictions, you suddenly don't expect many of these fetuses to reach term. If at all we get to almost term, we will have many of them having stillbirths because most of our screening is quite lacking. And like we can demonstrate, most of the screening should be done as early as the first trimester. But in our context, especially in Africa, the 11 to 14 weeks or the first trimester scan is not a commonality that we practice. Now it is upon us from the perspective of clinicians, the perspective of sonographers, and anyone concerned to this, that we take time and understand the techniques of doing this. Stillbirth in our context can be defined in different ways. For example, in Uganda, it can be fetal death at or greater than 28 weeks, but we understand in some countries, depending on how much intervention you can, some even go up to 22 weeks. Now, this shows us how serious and how people have gone ahead to screen and detect many of these anomalies as early as possible. Now, the common challenges in our setting is that, like I've said, we don't do early screening, the 11 to 14 weeks. Now, like we have seen, some of the complications is fetal growth restriction. There's no way you are going to determine or going to look for fetal growth restriction if you have not done the dating scan, because the precision we understand is at 11 to 14 weeks. If you don't have protocols, many of us, for example, you don't just do many of these Dopplers, you must have a protocol, both in the technique of doing these Dopplers and maybe in your screening. Dr. Sam has demonstrated to us the different biomarkers and the different imaging modalities we can use. You must have a protocol for each of these. You don't just use them independently or just anyhow. Then, of course, like Dr. Sam said, we don't just use, for example, if you're a sonographer, you don't just use uterine artery or maybe the thalamic PSV ratio. In solitary, it's a risk. Do we use logistic or competing risk models? Dr. Sam has ably demonstrated which models can we best use to achieve high sensitivity and precision. And of course, most of our equipment is lacking. Some of us are lacking in skill and competence, but it's one of the reasons why some of these webinars perhaps have to come up so that we can get new knowledge, get new insights of the new biomarkers that are upcoming, or how we can incorporate ultrasound. Ultrasound in the context of Africa has not been so much used. It is more used at the last tail end. But like you can see, if you do early screening, we have more chances of reducing the morbidity and mortality. Dr. Sam has clearly demonstrated the screening, the precision of these models. I won't dwell so much about this, but my take home is here. Ladies and gentlemen, my take home is here. We have two scenarios. We have usual practice, and then we have screening. Now, most of us, our practice is usual practice. So what happens? Most of us detect disease when it has demonstrated signs and symptoms. Now, what happens when we wait for symptoms and signs? Then, of course, that means the disease is already in advanced stages. Either, like Dr. Ngonzi has demonstrated, interventions can be done, but we don't know the end result. It could be good or be bad. So what do we have to look for? We have to come back and change our practice. We have to start practices of early screening. Now, when we start early screening, we introduce in something new. So we detect the disease before it actually shows signs and symptoms. Now, if you notice, the difference from the usual practice is that at a time when we detect the disease after signs and symptoms, until the final outcome, maybe which could be death, what we think is survival time is very narrow. The chances of survival or the chances of sustaining this pregnancy or preventing maternal morbidity or mortality or fetal morbidity or mortality, the chances are minimal. But when we detect disease before the signs and symptoms show what we call the lead time bias, our interventions are much more effective at this time. And at this time, what we would call the perceived time of survival is prolonged. If you look at in the usual practice down here, perceived survival time is short because that is the time when the signs and symptoms have demonstrated and until the outcome. Whereas when you do the screening, the perceived time of survival is when you detect the disease early until the final outcome is exhibited. Now in here, the perceived time of survival is much longer, prolonged. Let me give an example. If you have someone, you have maybe a cancer patient who's 60 years, and you have detected maybe the symptoms, and only this person lives up to maybe 65 years. The only perceived survival time from when the disease was detected, let's say if the signs and symptoms were detected at 60 years, and the person dies at 65, this person had only 5 years of survival. Now compared to this, now if this one was 55 years and they died at the same time, they all died at 65. Now this one, at least you detected the disease at 55 and they lived through 60 up to 65. So this one, because the disease was detected much early, had at least 5 years to live. Now when we go to the second scenario here, it's the same thing, but here, if all are 60, this one is at 60 years, but only gets the outcome at 65. And then this one is also 60, but we see the outcome has come at least some years or some time after the other one has gotten the outcome. So what am I trying to show in all this? That we must change our practice. When you do screening or early screening, you increase the chances of someone surviving complications, or you reduce the outcomes. For example, if it is preterm birth or stillbirth in the context of preeclampsia. So early screening is the earliest thing, is the best intervention we can start with, other than waiting for when the disease shows signs and symptoms. I thank you all and thank you for listening.
Thank you, Vitus, for a very insightful talk. Our last speaker, who is Edwin. I take the honor to welcome Edwin Ruhinda to the stage. Edwin is a fetal medicine clinical specialist sonographer, and also he also teaches for the Royal College of Obstetricians and Gynecologists, those approved programs, ultrasound in the UK. He is also the director of operations at Ultrasound Africa. Edwin is an ultrasound educator for us, very resourceful, and so we are glad again to have him on the stage tonight. And I want to ask everyone to please listen. He will be talking about
sonographer here in the UK with a special interest in fetal medicine, and my purpose today was to simply get everything that my distinguished colleagues have talked about, the very resourceful colleagues have talked about, and compress it into practicability. Basically, try to show it in case, in a case type of presentation. So before I proceed, I want to first steal from Vitus his last slide, which is showing on the screen, I hope. Are my slides moving? Good. So this is Vitus's last slide, and he was telling us about the telecom, and I liked this. That's why I stole it from him. So it basically shows you that if you do screening of a disease, it gives you ample time to adjust some things or some parameters within your means, which might help prolong the patient's life or improve the patient's quality of life. And this is the hallmark of screening, whatever kind of screening it is, whether it be it preeclampsia or any other disease abnormality. So this was a very important slide. And I want us to see if we're able to pick this this message within the case that I'm going to share with you. I have to apologize that because of the time constraint, I had to compress my presentation into one case, and then we'll try to work through this case together at the end and see if we're able to make sense out of it. So let me introduce you to patient X. Patient X is a 26-year-old lady. This was the first pregnancy. She's ethnically African or Black. Her weight at the beginning of the pregnancy was 65.9 kilos, and she's 1.64 meters tall with a BMI of about 24.5. Her blood pressure was normal at booking. Booking, I mean the very first time when she sees a midwife at the beginning of the pregnancy. This usually happens at about 10 weeks in the UK. So at booking, the blood pressure was 111 out of 70. And the other screenings that are done at the beginning, like the infections and what have you, urine tests were all negative and normal. So patient X came for a scan at 12 weeks and 1 day. That was by CRL. So she had the routine screening scan, which showed a CRL of 56.7, which is equivalent to 12 weeks and 1 day. The NT was 2.3, and we also happened to do uterine Dopplers, which are shown right there. And yeah, basically that was it for the pregnancy. At this appointment, routinely it is just to date the pregnancy and also screen for chromosome abnormalities, the 3 common chromosome abnormalities, which is Down syndrome, Edwards syndrome, and Patau syndrome. So this patient underwent the screening, and the results for the screening were as follows. So from the NT of 2.3 millimeters, the blood hormones, which are usually checked, that is free beta HCG and PAPA. PAPA is a pregnancy-associated plasma protein. So the PAPA was a bit low, to 0.11 moms. Usually you want that to be above 0.415 as recommended by the Royal College of Obstetrics and Gynecology. So in this patient, the PAPA was low. And some literature has shown that with a low PAPA, there's almost a 2 to 3-fold increase in the risk for this patient developing preeclampsia. So this at the back of the mind will come into play as we move along the case. But also, this low PAPA can be seen in chromosome abnormalities, especially Down syndrome. So because of the low PAPA, the 2.3 millimeters NT, her risk screening was increased for Down syndrome, which means this woman was told that there's a high chance that she might have a baby with Down syndrome. She was taken through the counseling and offered more advanced tests, which include the non-invasive prenatal testing and also invasive testing like the CVS. Of course, she declined the CVS and did the non-invasive one, which came back showing that it was all clear for all the 3 chromosome abnormalities. And this woman was happy to proceed with the pregnancy. For some reason, this lady presented to A&E or the emergency department with a slight bleeding. They did a scan and everything was clear and normal. But importantly, look at the size of the baby. The size was normal at 15 weeks. That's BPD, abdominal circumference, and femur length. They were all within the normal range. This is a scale showing the 5th centile here, the 50th centile, and the 10th centile. So anything falling in between these centiles is normal. Had these fallen below there, would be worried, but anything in here is normal. So the lady shows up again at 21 weeks and 2 days. This is when we usually do the screening for anomalies, physical anomalies on the fetus. We do this between 18 and 23 weeks. So she has this scan, but when you look at the biometries, they're tending more towards the 5th centile. The 5th centile is the very last line on that scale. So the biometries were tending towards the 5th centile. That is the head circumference, the abdominal circumference, and the femur length. The transcerebellar diameter was preserved, it's maintained within the normal range. This can be used as a boosting point for people who are proponents of using the TCD for dating purposes, because you can see in this case it wasn't actually affected by the growth compromise. But of course, at this stage, still the biometrics are within the normal limits, so it did not occur to the sonographer that there was something sinister going on. But then, given the context of the fact that we had a low PAPA, and then we're seeing a pregnancy that's tending towards the 5th centile, then you put 1 and 1, and then you begin to have your suspicions. So we scanned this lady again. Obviously, we scanned this lady between after the 21 scan. We scanned her again at 23 weeks, but I did not include that in here. This is another scan this lady had at patient X had at 26 weeks and 2 days. And on here we see, well, the head circumference is slightly better, but look at the abdominal circumference. It's less than the 5th centile. The femur length too is less than the 5th centile. Resultantly, the fetal weight is under the 5th centile, according to this chart here. The amniotic fluid was normal, and the umbilical Doppler was also normal. So this was being treated as a small baby. And between the 26 weeks and 30 weeks, this lady had multiple scans. Looking at the Dopplers, looking at the biometries, it was consistently a small baby, but the Dopplers were consistently reassuring. So the Dopplers, the ductus venosus, the MCA, and the umbilicals were consistently normal. I scanned this lady again at about 30 weeks and 3 days. Still, biometries were small. You can see this is 30 weeks and 3 days, but the head circumferences are measuring 29 weeks and 1 day. Abdominal circumference is measuring 26 weeks and 4 days, which is quite small. And the femur length was measuring about 27 weeks. So this was an overall small baby, and amniotic fluid was normal. So were the Dopplers, so umbilical was normal, MCA was normal, ductus was still positive for the A wave of the ductus venosus was still positive. And immediately after that scan, these are the biometries from that scan basically. So we're able to see that the biometries are all well off the scale, and the AC and the femur length are less than the 5th centile. In fact, they were less than the 3rd centile. The Dopplers were normal. And like I was going to tell you, after that scan, this patient was diagnosed with preeclampsia and HELP syndrome immediately after that. So she progressed into HELP syndrome, and that was the reason why they delivered this baby. This was at 31 weeks and 3 days, just about 4 days after the scan. She was delivered by emergency C-section. The baby weighed about 1 kilo. And the APGAR scores were 7 at 1 minute, 8 at 5, and 8 at 10 minutes. And the baby was admitted at the neonatal unit. So using this from when we started screening in the 1st trimester, and given the different telltale signs we're able to pick from the screening tests, obviously this patient was started on aspirin in the 1st trimester. And even with the low dose aspirin, she was taking 150 milligrams of aspirin once a day. And even with that, we're able to see that it didn't stop, or it didn't completely prevent this lady from having an adverse outcome before term, having delivered the baby at 31 weeks and 1 day. But I wanted us to now take a look at it differently. So did you know that just with these 3, a blood pressure machine, an ultrasound machine, and internet, somehow would be able to be alerted about patients' possibility of developing preeclampsia? And this, I want you to relate this to the context of Dr. Sam Ali's talk and Vitus's talk. And I'm going to show you how this is possible. And by ultrasound machine, I mean one that's able to do uterine Dopplers. So be more than uterine Dopplers. Internet, you can have it on your phone. So I'll refer to this graph, which this table, which I adopted from the Fetal Medicine Foundation Preclampsia screening course. And I want you to pay attention to that part there. It talks about the detection rate of preeclampsia at different intervals of the pregnancy. This is drawn from an assumption that all pregnancies, if left to go on indefinitely, if say you're able to get pregnant for 10 years, all pregnancies will eventually develop preeclampsia. So usually the screening is to tell which pregnancies are going to develop preeclampsia early or sooner than when the pregnancy actually stops, which is usually about 40 weeks. And using maternal factors, and I'll show you some of the maternal factors I'm talking about. So some of the maternal factors like race, smoking history, or obstetric history, some of those, I'll get to show you them in detail when we get to do this practically. But if you just use maternal factors alone, then you're able to detect 58% of ladies likely to develop preeclampsia before 34 weeks and 50% before 37 weeks, and then about 38% of those that will develop preeclampsia at term, basically after 37 weeks. But if you include, if you get maternal characteristics and you incorporate those with mean arterial pressure, then you're able to improve the detection rate to 65, 60, and 43. But I wanted us to include ultrasound because this is an ultrasound talk. So if you do maternal characteristics, maternal arterial pressure, and the uterine natal Doppler, then you're able to detect 80% of all women who are likely to develop preeclampsia before 34 weeks. And I think this is a very good improvement and a very important statistic for us to know that out of 100 women, we're able to potentially save 80% of them just based on simple things like uterine natal Doppler and blood pressure measurement. So, and this is 60% for those before 37 weeks and 43%, sorry, 70% for those before 37 weeks and 44% for those after 37 weeks. So what is mean arterial pressure? Mean arterial pressure is, you can do this, you measure the blood pressure of a lady, get the systolic and the diastolic blood pressure, and using that formula here, which is systolic pressure plus 2 times the diastolic pressure divided by 3. Whatever you get out of that is the mean arterial pressure. And for our patient X, remember the booking blood pressure was 111 over 70 millimeters of mercury, and this gives us mean arterial pressure of 84 using that formula. Remember, we also did uterine Dopplers at 11-week scan, and the right uterine artery PI was 1.84 and the left was 2.13. So the mean of the two is 2.0. So now I want us to go back to the first trimester at the 11-week scan, the 12-week scan, and see if we're able to use some of the resources that are available to us to see if we were able to predict that this lady would develop preeclampsia as she rightly did. So if you follow me now, I will exit the presentation and take you online. And I'll take you to this website of the Fetal Medicine Foundation. So let's assume you've performed your scan and you've done the NT and the CRL and you've done the uterine artery Doppler. So now what I'm going to do is I'll get either on my phone, on my laptop, I'll get onto the Fetal Medicine Foundation website. I'll get onto calculators. I'll look for preeclampsia screening, which is right there, and first trimester. And then right here are some of the things they want me to enter. So patient X, they're asking, is it a singleton or is it a twin pregnancy? This was a singleton pregnancy. What was the crown rump length? The crown rump length, I wrote it down, it was 56.7. which gives us 12 weeks and 1 day. And let's give a tentative date of about maybe, let's put it last year, September 29th. And date of birth, she was 26 years, so let's go back to 96. Let's say maybe the 1st of September. So now some of these are the maternal characteristics that I was telling you about that I would show you, and this is what they're asking about. So the height of the patient, I wrote it down here, it's 1.64, so 164 centimeters, and she weighed 65.9. She's black. Does she smoke? No, she doesn't smoke. Has she had preeclampsia before? No, this is her first pregnancy. And conception, it's a spontaneous conception. Does she suffer from hypertension? No, she doesn't. She doesn't have diabetes, type 1 or type 2, and she has no known ailment. So I've clicked 0 for all those, no for all those. And the obstetric history, she doesn't have any living children. She's not been pregnant before. Here is where we enter the mean arterial pressure of 84 that we got from our calculation. And the mean PI, which was 2.0. The mean uterine arterial doppler PI. She's doing the scan on the 29th of September. So you put it right there, 29th September. 29th of September. And so if you have maternal serum biomarkers that Dr. Samale was talking about, the PLGF and the PAPE, you enter them here. But now I'm going to use this in a, I'm going to assume I'm in a low resource setting with no credible lab that can run for me these biomarkers. So I'll say no to both PLGF and PAPE. So once I've filled in all my details, I would say calculate. And within a few seconds, yes, it will be able to calculate for me the risk. So from patient X's characteristics and ultrasound findings, this algorithm by the Fetal Medicine Foundation says that on the basis of the assessment, this patient has been classified as being at increased risk of developing preeclampsia before 37 weeks. The ASPRI trial. The ASPRI trial it was a robust multi-center clinical trial that was looking at use of aspirin in high risk pregnancy, high risk for preeclampsia, and it was trying to see the timing of when this aspirin should be used. So it was a very important trial, and if you have time, you can always go and have a read about it. But so that's what they are referencing on here. So they're saying the ASPRI trial has shown that in such women, low dose aspirin from now until 36 weeks reduces the risk of preeclampsia before 32 weeks by about 90%, and before 37 weeks by about 60%. So based on just this, if I'd done that scan, the 12-week scan for my patient X, and done the scan for patient X and gotten my parameters, the uterine arterial Dopplers and patient characteristics like what we have here, and then used the FMF algorithm, I would still be able to predict that this patient was going to have preeclampsia before 37 weeks. And then clinically, this would be very important when I go back to Vitus's last slide of saying, if you screen and you know, it gives you a lead time where manipulations and interventions can be done so that, one, you improve the outcome, two, you prolong the adversity, so you push away the incidence of preeclampsia, and three, you prepared. So you prepare the patient and you prepared yourself so that if there's any need for delivery sooner than expected, you're aware of this. And this is exactly what happened to this patient. There was an awareness that this patient is a high risk for developing preeclampsia. There was frequent follow-up. This lady had scans every week for Doppler, but 2 weeks for growth to look at the growth of the baby. And all this was because of the information that we had at the first trimester that this patient was at increased chance of having preeclampsia. So possibly had there not been an intervention, the preeclampsia would have kicked in sooner, because remember this patient was on low dose aspirin from before 16 weeks. And possibly had we not known that this patient is high risk for preeclampsia, no one would have followed up the lady and possibly should have developed preeclampsia or help along the pregnancy, lost the pregnancy, or even lost her life. So with that, I want to thank you for listening to me, and I hope you enjoyed the talk, and I hope you had something to learn from me. Thank you.
Thank you, Edwin, very much for this very insightful talk. So again, the take home is screening. Screening, screening, screening. So I will ask Professor Joseph Ngonzi. I know that you're into the clinics as well as teaching. Maybe if you could unmute and we just have a chat, a talk on this. You're in the clinics, you see these mothers daily. What is the screening in Uganda or the low resource setting? You know, we can always extrapolate that to the other countries. Are you emphasizing more on these dating scans, this early screening?
Benjamin?
Yeah, Professor is no.
Well, I mean, for the mothers who come in within the first 3 months, we definitely do emphasize an early scan as one of the mandatory tests or investigations that must be done. Yeah, it's something that is emphasized at least at many or most of the antenatal clinics. Yeah.
Okay, thank you very much. So that means that so if we are able to add the mean arterial pressure as well as the Dopplers from the scan, then we'll be able to really catch this 80% that Edwin is talking about. If the mothers are already doing the dating scan early on, so adding the mean arterial pressure and the uterine artery Dopplers, then I think we should be able to pick the 80% in the low resource settings. Yes, I know that we don't have really these advanced ultrasound machines in the low resource, but I would think that with already what we have, we can be able to do something. Sam Ali, I know you've been into the low resource settings quite a lot, and you see all this. Sam Ali, doctor, if you can unmute. What is you think that there are many ultrasound machines? What is are there many advanced ultrasound machines that we can rely on, or most of the low resource settings is mainly the basic ultrasound scans?
Yes, thank you, Jeff, and thank you, everyone. Thank you, Edwin, for that wonderful case, and Vitus for that very wonderful talk. Yes, I think, of course, Jeff, what you highlight is a very pertinent issue, and this is one of the things that have come up when we are listening to some of the previous studies we've done on ultrasound. And the issue of access to ultrasound is really there. That's the truth. I think nearly more than 50% of the women, I must say, don't have access to ultrasound, even if we say ultrasound is there. But there are many ways this can be possible, and I'm very pleased to work with a few people who are trying to think about handheld devices.
and also embedding AI in them. I think Professor Papajoji was in Makerere. He presented something on a portable ultrasound device, which has actually AI. You just do a single, anyone can do a sweep, and this AI tool could actually estimate gestational age event for someone who is doing a sweep. So if we, in the nearby future, we can make this accessible like this, I think it will somehow address the challenge of access to ultrasound. We must also think about models that work with basic ultrasound, not very advanced technologies. And maybe this is something that would be favorable. Like for instance, I draw a learning from the ADNX model. What you need a basic ultrasound to try to classify whether it's an ovarian malignancy or not, and also try to stage them. So, and I'm pleased that one of the groups or students are mentoring are actually doing some of this, trying to do some small study to pilot and validate this on the next model in our setting. So that's what I would think about. We need to just, we don't have to sleep. We have to work so hard to ensure that we bring this technology to the people who need it the most. That's going to be the challenge, but it doesn't prohibit us from exploring novel technologies. I must also hint that there are groups that are thinking about wearables, wearable ultrasound, like a new patch. I think this has been on social media for MSK, and probably in the near future this could also be possible for Doppler systems. So what we can just look up to is research that addresses our challenges. But yeah, that's what but access is still a challenge.
Yeah, thank you, Dr. Ali Sam. So the reason I asked you is we have, I know we have in this webinar, we have policymakers who are present and they are listening. So I just want to urge them that as they make these policies, there's a need for us for them to actually increase on the budget, the health budget, and this should be going into the screening. So we are able to, catch, in order to predict that these mothers are likely to develop the preeclampsia at this level, and in a way, kind of reducing the fetal death and the maternal death. And so at this moment, I'm just going to open the stage for questions. I see already there's a C. What is the normal thickness of the placenta? That can go to Vitus probably.
Can I answer that?
Yes, please.
There's quite a number of limits that have been suggested, and approximately 4.5 centimeters, that's about 45 millimeters. But these are measurements that have been done not in the context or within our population. So the fact that we are looking at this preeclampsia in the context of Africa, maybe perhaps let's give it time. It will give us much more population-based evidence, but it's around 4.5 or less centimeters. But the challenge is many of us are going to take this measurement as a Bible truth, but these measurements are dependent on the person taking the measurements or how you capture these measurements. We usually prefer you must be perpendicular to the placenta. Now you're going to get challenges of placentas whom you are not perpendicular to, unless you align your beam to have a perpendicular placenta, it's going to give you a false positive results. So you must take note of the confounders.
All right, thanks, Vitus. The other question coming in is, what are the best times in terms of gestation age for sonographers to assess the uterine artery? I think Vitus or Dr. Sam, any one of you.
Maybe like Edwin has demonstrated, the earlier you do this screening, like Edwin has demonstrated, 11, 14 weeks, the better. But like I also said, we have early onset. It may set in at around between 20 to 24, but you have seen in Edwin's case, it started from around indeed 24, and by 30 weeks, it was demonstrated. So we have early onset and we have late onset, but you have seen ultrasound is more effective in early onset, or when you do screening in the early first trimester. So you can do it all across. There's no restriction, but we have seen the best time is when you do the screening.
Yes, thank you, Vitus. Of course, I think I want to supplement. The best time is early, early if possible, because it compromises the whole goal of prevention if you focus on screening late. But of course, it's also possible to, if a woman presents late, if you can think about applying these models. And I think I've presented in one of the studies I presented, it's also possible to actually screen a bit late and apply the models. Though the best should be us encouraging our women early. But one of the most interesting trends we are observing in iTech is that, and even in previous studies, for sure, most of the women present very late. And of the women who are presenting very late, they are the majority who are experiencing adverse events. So restricting the screening to very early pregnancy may be a bit limiting in trying to avert this burden of preeclampsia and the associated morbidities and mortality. So I would say let's emphasize early, but also try to apply these models later if possible. And I would also, of course, not encourage the use of absolute thresholds for most of these parameters, because most of them are affected by the gestational age, so they are gestational age specific. And for most of the parameters, I always recommend look for a good chart, reference chart based on very good evidence, and use gestational specific thresholds for making those decisions on what is the best cutoff. I think that's what I would recommend, in addition to what Vitus just said. Yeah.
All right, thanks, Dr. Sam. So someone is saying, if possible, can you send the file via WhatsApp? Yes, so we have a YouTube channel. You can always access the YouTube channel via our website, www.ultrasoundafrica.org. So you'll find a link at the top of the website, so you can follow this webinar, the recording, on the YouTube. The other question is when
Jeff?
a person has, yeah.
Oh, go ahead. I was going to say we have 3 hands up, and I wanted to unmute them. So when you're ready.
Yeah. So someone is asking, when a person has high blood pressure before pregnancy and gets pregnant, do we classify that under eclampsia? So we have someone really mixing up a few things here, but Professor Joseph, I think he's gone out because of time constraints on his side. Probably Dr. Sam Ali, are you able to answer this question?
I think I can ably respond to that. I think when you look at my first slide, I just did still re-echo the same message. If somebody has hypertension before 20 weeks of gestation, then this is not preeclampsia. Probably they could have had this before. So it's basically hypertensive disorder developing after 20 weeks of gestation, and if there's no proteinuria and other features, then it is basically just gestational hypertension. But if there are any other features suggestive of maybe proteinuria, maybe depending on the level of the systolic and diastolic blood pressure, so you can either have mild to moderate, but should be after 20 weeks. Yeah, and of course, like he did mention, this can also persist, but should actually ideally resolve after about 12 weeks. Yeah, 6 to 12 weeks. And yeah, basically what I would also want to emphasize is that at times, if these women, if it doesn't resolve, this preeclampsia itself has still long-term effects on the women and the babies. So it would just be nice if we could encourage them to attend early and screen and try to prevent at our best. Yeah, thank you.
All right, thanks very much. I'll come to the hand, but before that, there's a question here. What's the difference between, okay, this is, I would like to ask, how can preeclampsia cause IUGR, intrauterine growth restriction? Edwin? That's Gerard asking that how can preeclampsia cause IUGR? Edwin, you're muted. If you unmute.
Sorry. So there's a whole complex pathophysiology of how adverse outcomes are a result of preeclampsia. But think of it this way: if there is a compromised perfusion within the placenta, either because of pre-existing maternal conditions like hypertension or as a result of things like preeclampsia, it means that you're getting compromised perfusion to the fetus, to the baby. The same thing happens with if you have maternal disease conditions elsewhere, like renal disease and liver disease. It's the same thing. So if you have these conditions affecting how blood flow, how basically how the placenta is perfused, then it in turn affects the baby.
All right, thanks for answering that question. Now we'll go to the hands raised, and let's unmute a few of the hands here.
So we have, I'm going to unmute Elisha and Subuga. Your microphone is able, so you can unmute on your side and ask your question.
I want to thank all of you for the presentation. I want to ask Edwin from the case he presented, which was a very good case. I wanted to ask, how often do you follow up these patients? What would be the timing or the routine of following up on these from the Doppler perspective? Thank you.
Oh, thanks, Elisha. So I'm not sure if you mean right from the first trimester or if you mean when we notice the Dopplers are abnormal.
Yes, when you notice either way, if you could answer both, but most especially when you notice that the Dopplers are abnormal.
All right. So in this case, the uterine Dopplers. Okay. In this specific patient that you saw was followed up because the baby was small. Remember, in this patient, the fetal Dopplers, the umbilical Doppler, MC, and the ductus were all normal, all through to the very end were normal. So the follow-up wasn't on the basis of the abnormal Dopplers, but because of the size of the baby. The baby was measuring under the 5th centile, which was a very small baby. When the baby is that small, usually you want to follow up and see that the Dopplers are maintained in normalcy. Basically, you don't want to intervene when the Dopplers are normal unless there are other confounding factors outside the fetus, maybe the maternal factors, like in this case where the patient developed HELLP syndrome. But had the Dopplers maintained to be normal and the mother was stable and the blood pressure normal, they would have tried to prolong the stay of the pregnancy up to a time when it is a bit, where you would say it is independent, which is term. So you go towards term, but if you can't, then you intervene. And the reason the way you tell the difference is if you do weekly Dopplers. So every week you assess the umbilical, MCA, and if need be, the ductus venosus, and then 2 weekly growth scans. So a gap of 2 weeks before you do biometry assessment of the fetus to see the baby's growth. So it really depends on. There's no one single pathway that will fit all patients. You have to make a judgment and say this patient will need to be assessed every week to look at the Doppler. So this patient will need to be seen every 2 weeks. And if it's stable, we can maintain at that. There are some patients where you'll be scanned every 2 days to look at the Dopplers, just to look at the Dopplers and try to inform the timing of delivery. Yeah.
Thank you.
So I'm going to unmute Japhet Tele or Tele Japhet. Okay, you can unmute on your side, Japhet.
Hello, everyone. First of all, I'd like to thank everyone for the presentation, the two professors, Mr. Vitus and Mr. Edwin, on the wonderful and comprehensive presentation on this topic. It's truly been enlightening. The only question I have is, I've had the predictive value or the prediction of preeclampsia, including previous preeclampsia or multiparity and even nulliparity in predicting preeclampsia. My question is, on the basis of placental or structural development of the placenta, is there any basis to the structural development of the placenta or underdevelopment of the placenta in relation to preeclampsia? And is there any sonographic means that we can predict preeclampsia in relation to development of the placenta, whether that is in relation to penetration of the placenta, syncytiotrophoblastic development of the placenta, or any form of structural development of placenta in relation to preeclampsia prediction. Thank you.
Vitus, do you want to take this up?
Yes. Thank you for that question. Yes, of course. If you noticed, Dr. Ngonzi hinted on this. Usually, so far there are two suggested means by which some of these hypertensive disorders come about. One of them indeed is placental or trophoblastic invasion. And now what is it about? For example, okay, this is work that we are doing in ITech. I don't want to, I'm conflict of interest, but what happens is, for example, how many spiral arteries or how many fetal arterioles, or what is the perfusion within this placenta? It affects, all this goes back to the chain of affecting maternal hemodynamics, which is centralized on the maternal cardiovascular outputs. So it could either come from the trophoblastic invasion or placental anomalies, or it could actually start from maternal cardiovascular complications or events, because pregnancy basically affects maternal cardiovascular system. So depending on the adaptation of the maternal cardiovascular system, the whole event, be it the placenta or the maternal, triggers what we call the endothelial reaction. Now that endothelial reaction is what sets in these hypertensive disorders. And that's why we have to do the uterine artery to determine, is it caused by the placenta or it is the heart. But the whole thing is about maternal hemodynamics changes.
All right.
It's complex.
Edwin, what is the standard follow-up time for ultrasound after getting a positive ultrasound finding for preeclampsia? This is a question from Mabilisa.
So when the patient is diagnosed with preeclampsia, it means there's protein in the urine and there is a high blood pressure. The only remedy to preeclampsia is to deliver the pregnancy. Obstetricians will tell you that preeclampsia is a disease of pregnancy, and the only way to alleviate preeclampsia is to deliver a pregnancy. If there's a way of suppressing the blood pressure and prolonging this pregnancy safely for the mother and for the baby, then the pregnancy will stay. But this you have to do in constant evaluation of fetal aspects like Doppler and and amniotic fluid, and also maternal aspects like blood pressure and urine tests, of course. So how frequent should the ultrasounds be done? Depending on how small the baby is, depending on the growth velocity from the previous scans, you might be doing these scans every week to look at the Doppler and every 2 weeks to look at the growth of the baby. And if the pregnancy cannot be prolonged further than should, then delivery will take place, obviously. So the Dopplers will not, ultrasound in itself will not dictate whether the pregnancy is delivered or not. I don't know if I make sense. There are also other factors that are considered in whether the pregnancy is delivered or not. But the role of ultrasound in this is to check and make sure that the Dopplers are still normal, so there's no compromise on the fetal aspect of it, and that the amniotic fluid is normal, umbilical Doppler is normal, there's no reversed or absent end-diastolic, MCA is also normal, and there's some bit of fetal growth in terms of fetal weight gain, basically. So if you have those, then on the ultrasound aspect of it, it's okay. But then there's also other aspects. There's maternal, there's CTG, there's all the other things that are considered before delivering a pregnancy. Thank you.
Thank you, Edwin. We'll have one more question from, I see a hand over there, and then we'll close after this question.
Amos Nwaga.
Amos, if you unmute your side, you should be able to speak.
Thank you very much, Ultrasound Africa, for bringing us these distinguished speakers on the subject. My question is on ophthalmic artery, so to speak, ocular ultrasound. My question is whether there are technical consideration for performing ocular ultrasound in regards to stuff like thermal index and whatever, because I've seen some equipment, really good equipment, where they indicate that the performance of ocular ultrasound is contraindicated on the basis of thermal index. However, I also took note that if you reduce the acoustic power, so to speak, you also reduce the thermal index. So I want to know if there are in such equipment where it is indicated in the manual that the ocular ultrasound is contraindicated for that specific equipment, if there are any technical aspects you can adjust and be able to perform this important test. Thank you very much.
All right. Vitus, are you able to take on this one?
Yeah, one of the challenges and one of the recommendations as safety measures in ocular or ophthalmic artery ultrasound, we have to take into account the mechanical index and the thermal index, and the thermal index for the tissue to bone interfaces. Of course, most of the old equipment, it's about acoustic powering output that you control. But the good thing is that, for example, the equipment we are apparently using, the recommended mechanical index, a maximum should be 1. Even the tissue index should be less than 0.5. But the new equipment that is coming out is the mechanical index can be reduced as low as 0.5, and the TI can be reduced as low as 0.1, which is absolutely very safe, both for the ophthalmic artery and for acquiring good images, but also gives better safety. Now, in the resource, the powering of those machines at least to less than 1. 1 is safe, but many of our machines, the current trends, At least I happen to know the machine Amos is using. It can go to less than 1. So thank you.
All right. Thank you, Vitus, for that. And with this, we have had 4 speakers give very insightful information and share their vast experience on the topic of preeclampsia. And right now, I'll close the meeting. Thank you for attending. Thanks again. We'll see you again in our subsequent webinars. And the next one should be coming up in November, and that will be on breast ultrasound, coming in from Professor John Skill, Washington, D.C., the United States. All right, bye-bye. See you.
Thank you.